I'm very happy to be here because first time I'm in Leipzig and first time I'm in a conference on digital health where I don't know anybody. I worked before joining the North Estonia Medical Center team in Tallinn. I worked in the European Commission and on digital health policy sector, leading it. And that's very positive emotion that I get with the group of people I have not met in my work in this area for 12 years. So that's absolutely wonderful. I don't know what was by heart the title of my previous speaker, but I got an impression that it was something like why we can't do it. I want to tell you how we have done it. Because I just read from the news that Estonia has been counted as the per capita most of the AI companies in Europe. And I think that somehow describes the attitude that we have towards the digitization in Estonia. And maybe it's also because the country name is like Estonia. So we have to do something on that. Just a few slides to set the scene. I have understood today with different discussions that actually it is a surprise that Estonia is so small. We are 1.3 million people only. If somebody asks where it is, then usually we say go to Finland and turn right. Then you will get there. We actually contribute quite little compared to the European average to the healthcare system from the GDP. But other studies have demonstrated that nevertheless we are able to use it most efficiently. So, consumers do not necessarily be happy about that, but that's the situation as we are. And as all other Western countries, we are facing the same problem with the more multimorbid citizens, with the higher demand and with less resource. I would not say as aging as a problem, because I think that aging is a benefit, aging is an achievement that we have got thanks to the developments in medicine. So that's a positive message, which comes with some challenges, and we have to face it. I come from the one of two third-level hospitals in Estonia. You see, we don't have so many of them, but two hospitals, the North Estonia Medical Center in Tallinn and the Tartu University Hospital, provide a third-level service with all specialties, except we in my hospital, we do not have pediatrics and we don't have obstetrics. So the happiest part of medicine is unfortunately not in our hands. So the workforce situation actually is the same as everywhere. We have to really think how we get there to improve the quality, to improve the service, accessibility, and in principle also provide for the universal health coverage. Even we think sometimes that that is a problem somewhere in Africa. In principle, the universal health coverage is also the problem in big cities. If you look at the metro station, different life expectancies. And the same is with Estonia, where we have 2,222 islands. And not in all of them people live, but in many of them people actually live permanently and they deserve the similar access to healthcare. So in principle, the digital tools gives the possibility to access these people and to provide them with the service and the advice that they need. My second slide is just to describe the basic principles that we follow while doing this innovation. The title I put here is my personal understanding, because we often have there is like parallel streams. People talking about value-based healthcare, then people talking about personalized medicine, or precision medicine or stratified medicine, however different countries call it differently. And then we have this patient-centric healthcare. In my view, they're all the same. Because in the end of the day, they all aim at achieving the best result in healthcare service that we provide, starting from the prevention, ending with the rehabilitation, palliative care, and hospice. But the principle is the same in all of them. So the principles applied are similar. Engage necessary stakeholders, use the knowledge that exists in each level, engage patients, because from the hospital point of view, what we can say is that we see our patients, let's say, oncology patients perhaps more often, but on average, maybe 1 or 2 times a year. But the patient is with the disease all 365 days. So the best knowledge of their condition, their quality of life is with the patients. There was I can't say that it was nice because it was a serious film, but it was well done, let's put it this way. The Norwegian film about a stand-up comedian who on the same day got the diagnosis of cancer, got fired, and divorced. Well, it was a bit of comedy, but it was from this kind of laugh through tears approach. And in one of his sessions where he was trying to make people laugh, he got to his condition and he used a sentence that I very much like and have quoted many times. He said that patients are unused resource. And I think that is very true. This unused resource that we could complement the healthcare system with are our citizens. Of course, there are some prerequisites to it. With the digitization, certainly one claim often used is that we are creating the digital divide. This is from 2022. The percentage of people having used internet in last 3 months. In 2014, we did an Eurobarometer. At that time, I worked in the European Commission. We did an Eurobarometer on digital health literacy. And we asked people whether they have used internet for searching information on health or disease. And in 2014, it was 6 out of 10 people who said they have done it. The problem in my mind is that how they usually do it. They go to Google search, and what are they looking for? They describe a symptom. Pain in the left ankle. Stomach pain. What Google gives them is not necessarily evidence-based and justified source of information. But the patients do not make a difference if their level of health literacy is not sufficient. 2011, Maastricht University made a survey all over Europe analyzing the level of health literacy of European citizens. And it turned out, according to that survey, that only in one member state, and that was the Netherlands, where there was more than 50% of people who had sufficient level of health literacy. What do we mean by health literacy? It's the same as we mean by literacy. You can read, you can understand, and you implement. If you take statistically that since 1930s, we know that smoking is bad for your health. I don't think there is a citizen in Europe who doesn't know it. Yet 20% of people smoke. So they know it, but they don't implement it. And that is a big gap that we have to work on. How can it be that people don't understand how mRNA vaccines work, but they understand how ivermectin works for COVID, which for me is mystic. But there is bigger support for this type of medicines than there was for vaccination. And we know what is with this vaccination. So basically, yeah, that's a problem. With this data taken into account, we have to deal with this question of digital health literacy. And by the way, not only the citizens, the healthcare professionals as well, they do not necessarily know where to search. And sometimes, maybe you have even noticed, doctors also Google. Here, now, having said all that, this is what we have in Estonia. The services that we have available nationwide. And, well, I would say that engagement of patients is not necessarily in all of these, but the patients certainly benefit from all of these. For example, the medical images bank, or the picture bank as we call it, we don't give an access for patients, but they get all the descriptions given by the radiologist in their patient portal. So they do not necessarily have to have the images, because that is the huge amount of bytes that it requires. Then also, the e-consultation between specialists is not something that patients can do, but they can ask for it. Because in principle, I would say that Estonians are very specialist-oriented. I think it's important to convince that general practitioners can actually treat 70% of the diseases. Well, as those who have medical background here, you know, 70% of diseases will go away anyway. So the role of a doctor is make a difference. Which ones have to be referred to a specialist? However, in the past, it was basically the decision of a patient which specialist to see. They, for a back pain, obviously, I need to see a neurologist or neurosurgeon, even better. While it is a condition that GPs can handle perfectly well. Also, to monitor the chronic conditions that can be perhaps diagnosed and first treatment applied by a specialist, but then later the treatment can be handled by a GPs very well. So what we have, this e-consultation, is an opportunity to not necessarily put the patient in the waiting list for seeing a specialist, but what we send to a specialist is data. So that the GP puts the e-consultation into the system, puts all the relevant data, description of patient condition, objective findings, subjective findings, and send this information to a specialist, and the specialist within 3 days will give a result. Either just will respond, continue the treatment as initially planned, or can take the patient over and invite to the appointment. And the good thing in it is that the patient doesn't have to endlessly call to this receptionist where you need to create an AI to respond, or use the digital registry for the patient, which is also an option in our case, but can, according to the information available and the seriousness of the condition, can have an appointment tomorrow, in a week, in a month, according to this information that is given. And I find that from the patient safety point of view and access to medicine, that is far better solution to prioritize the waiting list. So not directly, but indirectly, patient would benefit from all these systems. Personalized medicine project, how our patients get into this. We had a call for all voluntary citizens to donate blood for our genome bank. 250,000 people did so. So you have sequenced your genome, and if some kind of risk score has come out from it, for example, the risk for the breast cancer or for the risk of the familiar hypercholesterolemia, you will be invited to the appointment. Of course, with the condition that you want to be informed. Because, from the patient rights point of view, I think it is also a very important right to not know. I think we nowadays know quite well the genetic precondition for developing Alzheimer. But as long as we do not have a treatment for it, would you like to know that that's your future? Will you do 2 Sudokus a day? Yeah, well, I personally don't want to know it. So, but for some risks, like the breast cancer or the hypercholesterolemia, the patients will be contacted via GP and asked whether they would like to participate in the project. Because with breast cancer, that's one type of counseling, but with familiar hypercholesterolemia, for example, there is another type of counseling on the lifestyle, and perhaps the statins as well, it comes later. In our patient hands, there is actually quite a lot of health information that we don't use. I tried to put here all kind of health information that is available in Estonia, and I'm sure that it's not complete. But, for example, information about loyalty cards. My grocery store knows quite well what I eat. My family doctor doesn't. Because I tend to lie, perhaps, as well. Pregnant women, when they are asked whether they smoke, nobody does. But one research that was about pregnant women smoking, measuring the cotinine, showed that actually there are smokers. So this information would, in particular in terms of person's prevention, be very valuable if we want to put all this information that we have about me, about my habits, about my living address, about the environment in which I live, in order to contribute to this personalized medicine or value-based approach, so that it would really be valuable from my, as the patient, point of view as well. Otherwise, well, we have quite a lot of information on our tools. I used to have the watch that was measuring my steps, and I have to say that I liked it much more than my telephone data, because I had so much more steps in the watch than in the telephone. So you see how biased we are actually with this. Patients also have an access to patient portal, to all this information which is made available to them, to their related to their health. Again, GDPR does not define the term ownership. Health data are not owned by anybody. We have the legal obligation in the hospital to store the data. We have, patients have the legal right to have an access to this data, to get a copy. But the ownership, that means that they can also delete it. But that is not possible. So this ownership question is not discussed in the GDPR. But they have access to it. What patients can do with this information, they can hide certain information if they do not want the other doctors see it. But here is another question related to this question of health literacy. If I will hide information about my health condition, can I be sure that I receive a treatment that actually is correct? There is no interaction between medicines. Actually, the prescribed medicines you cannot delete. That is visible for everybody. And the e-prescription provides also the automatic support for finding antagonists, synergists, all these kind of things, controls your dosage, that it's corresponding to the age. So, and their patients cannot interfere. But with the diagnosis and the doctor's visit, they can. But again, we have to support them with the knowledge why it is important. Then, what else that we can do? The telemedicine. I think telemedicine is as old as telephone. And it's very popular. Very difficult in our hospital to switch doctors who have used telephone consultations, in particular when it is to describe the results of the analysis or something about the next steps or the change in the dosage of medicine, to video consultation, because they can perfectly well do it over the phone, and then that's some kind of new tool they do not necessarily want to take on board. But I have to say that our psychiatrists have very well adjusted to the video consultations, and they like this tool. And the good thing is that with telephone calls, we do not have this possibility to identify who is on the other side of the telephone. But with video consultations using the Teams, where you have an access via the digital registration, and in order to have an access to this registry, you have to identify yourself and authenticate yourself with the electronic ID. It is secured. Nobody else can interfere with your visit. So telemedicine, we also do quite effectively with our small island project, where we do not necessarily in all our islands have the medical staff present, but we have voluntary people who have been taught to provide for the first aid, and they have the connection with our hospital emergency department via the teleconnection. And they use the German tool Corpuls, which if you apply on a patient will be automatically connected to our telemedicine doctor screen, all vital signs there, the ECG, the blood pressure, and you can also have the video connection in order to see the patient. For example, to diagnose the stroke, sometimes you need to see the patient as well. And with that tool, we can support this first aid group, the voluntary, non-medical, but trained people, to provide the first aid on the spot or decide that, yeah, we have to send a helicopter. So these kind of telemedicine tools are also the monitoring, for example, for the pacemakers. The patient nowadays do not have to come to the hospital to take the reading of the pacemaker, but it can be corrected from a distance. And that, of course, reminds us that we are so openly talking about GDPR in all aspects. But I find that from the life-threatening point of view, cybersecurity is even more important. So if you apply in your hospital the GDPR rules, that's an obligation. But you also have to ensure that nobody can hack into your system. You know, as it was with this, I think it was like 5-6 years ago in the UK, the case where they hacked into the system. And I heard in the European Society of Cardiology presentation, somebody from the UK hospital said that, and then we went to the hospital in the morning and there was 700 patients and nobody knew what's wrong with them, because all records were closed. So cybersecurity is very important, and with the medical technology we have to consider that aspect as well. The decision support system, not only for doctors but also for patients where possible, and I will come back to that in a few minutes. What I also think is an important tool that we could use using the digital tools is the collection of patient-reported experience and patient-reported outcomes and patient-reported incidents, because we know the incidents that take place in the healthcare premises, but we actually don't know much about what happens afterwards. And sometimes the incidents will take place at home. So these three, PREM, PRIM, PROM, are very important in order to move towards this personalized, value-based, patient-centric healthcare. Two good examples that we have tried and implemented in our hospital. One was for the stroke patients, where we provided them with the mobile telephone tool for all information necessary, where they also can note the appointments. You can imagine that with stroke patients, not all patients are capable of using the digital tool, but there were almost in all cases relatives who were happy to help, because sometimes the knowledge about the disease and how to move, what to do, was even more relevant for relatives. And as we have learned, sometimes when the patient comes to the appointment alone, then it's perhaps 20% that the patient will remember after the visit, in particular if that visit is difficult and the subject is complicated, let's say oncology diagnosis or some kind of degenerative disease where the prognosis is not good. So patients in general are not capable of absorbing all this information that you give. So they come with somebody. And good if they come with two of them. And then what we have learned is that there are two daughters and they both remember different things and sometimes opposite. So providing them with something which is available afterwards, all this information, what next, what kind of medications, when will be the next appointment, what is to be expected. Sometimes the disease doesn't go immediately better right after the visits. Sometimes it's good to see a nurse and it already gets better, the dentist. But in general, it can still get worse few days. And it's good if this information is written somewhere so that the patient and the relative can go there, read it, and get the confidence in this information being available. And from the trustworthy source. So this was this patient journey app. What we also learned is that the specialized nurse who will be your contact point throughout your journey is very valuable asset, because people do not have to call to a number somewhere in the ward, but they can call to a specific number and this nurse will be available there for them to discuss certain relevant, very important questions and plans. The shared information space, that is something that we learned because we have a quite good access to information and shared between the healthcare providers. However, with the stroke patients, that is also very important information space necessary for the social workers, because sometimes they require social assistance, and that link was missing. So what we created was this link. We actually used one of the commercial tools that was created in Estonia for this type of data flow, but it worked very well. Actually, everybody going to that information space, noted down what they have done, and everybody else who was involved in this patient journey saw what the others have been doing, so that to avoid the repetition and also share the information about the patient condition. The community support we used by actually directing patients to the services that they need, because sometimes they either don't know where to ask, or they forget it. And then the direction to the rehabilitation or to the groups that are working on the speech problems, for example, that was very welcomed and they really liked it. We also updated the website, because with websites, you know how it is, sometimes we forget that they need an update and they become outdated and not so user-friendly. And we also had here a collection of PREM and PROM, so that we would get the feedback from these people whose opinion is most important. The on-contact project is another one that we focused on oncology patients. Actually, the oncology patients were the first ones in our radar, but it took a bit longer to launch this patient journey project. And what we aimed at was to start using the platform, which is an online platform created by Finnish company Kaiku Health, where patients can submit their questions, describe their symptoms, as well as report this outcome according to the schedule as it is set by the ICHOM standard. And we also have on that platform a tiny part of artificial intelligence, because patients very often have similar questions to which the answers have been also given already 100 times. And the AI, by recognizing these symptoms, can guide them at the first step. But if the problems are serious enough, then the patients will be directed either to the consultation with the nurse or with the doctor, or if necessary, it also gives an advice to call for 112 immediately. What we have got the feedback from patients is that it is kind of security platform for them, because they can go to that platform anytime. The symptoms, patients in general feel worse in the evening during night. And having this possibility to describe your condition half past 1 in the morning, that gives them this confidence that they can have maybe the first advice. And if not now, then first thing in the morning, the nurse will look at all this information highlighted in her dashboard to see and get the contact and to give the right advice for the patient. And that actually, we already learned in Estonia more broadly with the education on sexual health for young people, where this type of tool for the web consultation was created already in the end of last century. And it was important because young people in particular didn't want to go to the women's clinic or to any healthcare professional because of different reasons. One of them was just to be caught by the mother or teacher to see that I have a question. And the majority of young people questions in that field are quite trivial, actually, mostly related to the question, am I normal if I have this problem? And it turned out that they used a lot of it. And they also we created this frequently asked questions site where they can, before submitting your question, you actually can check maybe somebody already has asked that question. And it turned out that, yes, there was quite a lot of similar questions. And if not, then it was not some kind of unknown advisor, as it is, these kind of advisors on the physical activity and what to eat all over the web. We had the trained, specialized people who did it. And that gave the confidence. And I think that is also this question of confidence in this platform, because people know who they are talking to, even if it is online. And it's a good tool also to collect these patient-reported outcomes, because in the end of the day, it is very important that we measure it, what we do. Some more things that we are working on. This collection of patient-reported experience, we have done ourselves. We collect in the hospital once in a quarter. We send an SMS to all patients visited our hospital in that month, and expect them to reply to 12 questions, with most of them with the scale. However, there is one question of free text as well. And that's the most important answer, actually, this free text, because that is where we get the knowledge that we can use in order to improve our services. The patient-reported outcome, however, is a very expensive tool to collect. We try to procure the platform. But then it turned out that for one disease, 1 year, the collection, the platform is 30,000 euros. 1 year, it doesn't make any sense. So now our health insurance fund is going to procure the platform for Estonia. And I'm very happy for it because in principle, the outcome is not relevant always to a disease. It is relevant to the patient because if we, for example, collect an information about the quality of life, then that can be influenced by what this WHO survey said. People above 65 years had at least 5 different medical conditions. So there are more medical conditions that influence my quality of life, and I am not necessarily treating all of them. Probably the GP is looking after all of them. I look at one as a specialist, and that's why this type of platform to be available for all doctors or nurses accompanying this patient journey, that is very important. Then other patient pathways that we are introducing in my hospital are listed here. And the patient pathway does not necessarily have to be something with a chronic condition. Sometimes it is from the moment of the entering the hospital. Sometimes it is from the moment of first symptoms. Sometimes it is finished with leaving the hospital, but sometimes it is years after the hospital treatment. So how to put it all together to have this patient journey smooth and seamless, that is something that we are working on. I think that endoscopy, you can imagine that that's a procedure, that the preparatory phase and then the procedure, and not necessarily years after. So that is what we do. We are also working on this patient's health literacy in terms of understanding that health data is a public good. And that is based on which we have achieved what we know now. Health data is not something new. It didn't come with the digitization. It has been there since Hippocrates. So that is the understanding that we want to grow in our citizens. And I'm very happy because a lot of work, a lot of knowledge and evidence about the importance has been collected by the European Patient Forum. And Germany is also very active in that field. We are learning from your experience. And the digital health literacy I already discussed. I left 1 minute for the questions. Thank you.
So